everyone, it's Diane here again, and I am delighted today to be talking to Anne Henderson. Anne is a consultant gynaecologist and she's also a menopause specialist. So I'm going to ask Anne to introduce herself. She just asked me, do I edit this?
I've got my coffee at the ready in case I get stressed.
So Anne's going to introduce herself, tell you a little bit about her, and then I'm going to ask Anne some of your questions all about duty of care and struggling to get the right treatment, etc. And I hope we're going to be able to give you some answers that will help you go forward and get the right support and information for you.
Great. Hi, thanks, Diane.
You're welcome. Thank you for doing it.
Good. I am a consultant gynaecologist, as you said. I'm a British Menopause Society accredited specialist, and I believe there's 120 of us in the country, and there's 5+ million women, so you do the maths.
Yep.
It's not good. I have been practicing menopause for decades. I trained back in the day with Professor John Studd, who many of your listeners may know well.
Yeah.
Sadly, he's no longer practicing, but there's a few of his trainees like myself who are still going strong.
Yeah.
I've run menopause clinics for as long as I can remember, both in the NHS, both privately.
And where do you practice now, Anne, apart from here in London?
Currently I practice in London and also in Kent, several hospitals in Kent.
Okay.
And having just audited my results, I think I'm seeing in the region of 700 patients a year. So it's a big workload. Obviously not all new.
No.
But that's my current workload across the spectrum. Obviously, because of the job I do, quite a few of those are high risk. They're complex cases.
Yep.
But within that number, there'll be some who are very basic, straightforward cases as well. So it's a full spectrum.
And do you do private and NHS in Kent, or is it not a possibility?
Well, at the moment, it's primarily private, both in Kent and London. But that's largely because of the service level agreement between the hospital I work at and the CCG.
Yeah,
it's not that I'm refusing to see
NHS this is
patients.
an issue that a lot of doctors and specialists are telling me that they'd love to do a clinic, but they just don't have the option.
So I see NHS patients for other gynae problems, but not menopause.
Okay.
And I have repeatedly offered to the hospital and the CCG to see patients on the NHS because I'm one of only, I think there's 3, there's 2 BMS accredited specialists in Kent, and I'm one of them. I know my colleague, the other colleague who's accredited, does have an NHS menopause clinic, but of course she can't see everybody.
Yeah, absolutely.
So there is a real issue about service level agreements and about who's running menopause clinics.
Yeah.
And there's no doubt that there is a need to expand the NHS side hugely.
Yeah, absolutely. We're sort of hearing it all the time. Yeah. So the reason that I specifically look how red I am. It's really hot in here.
Put the fan on.
Oh, it's fine. The reason I specifically wanted to speak to Anne was because she is a menopause specialist, but you also do medico-legal work.
Yes, I do.
Yes? So could you just sort of give us a sort of brief outline of what it is that you do?
So I do, in addition to my clinical workload, I provide expert reports for either the claimant or the defence. I'm instructed by lawyers in the first instance. Occasionally I'm instructed by the patient or the claimant herself. And I do a wide range of gynaecology and obstetrics, but one of the things that has crept onto my radar over the last 12 to 18 months has been the number of menopause cases, both premature menopause and judicial menopause, where there has been evidence of negligent management and the patients have come forward to seek legal advice.
Okay.
And I currently have about 3 on my books
at the
moment. Yes.
Okay.
Yes.
That's interesting.
Yeah.
So the reason I really wanted to sit down with Anne is because I thought she would be absolutely perfect because she has a combination of both skills to be able to give us some answers to some of the questions that come up on my private Facebook group, the Menopause Support Network, so regularly. So the first one is, and I'm sure you've heard it many times before, November 2015, we had NICE guidelines appear for menopause. Now, we all know that GPs have a huge workload. We know that 10-minute appointments are not
hopefully not for much longer.
Okay.
If you believe the media this week.
Okay.
Yeah.
That 10-minute appointments are not enough, and that there are NICE guidelines on lots of things. There's a huge amount to read. However, as you and I have discussed before, menopause is going to happen to 51% of the population. It is going to crop up all the time. It is costing the NHS a fortune in secondary care appointments, in women going back 6, 7, 8 times. So, when the NICE guidelines came out, a few months later, I contacted the GMC, NICE, the RCGP, etc., and asked them about the sort of legal duty to implement them. And I couldn't really get a very clear answer. NICE basically said to me, we produce the guidelines, we don't have any responsibility for implementing them. It's really down to the CCG, but there's no legal duty. Could you sort of share some thoughts on that?
Well, I think one of the benefits of the menopause guideline is it's 40 pages long. I mean, it's a very short document. I know when I lecture, I obviously encourage GPs to read it. It's very accessible. You can read it in 30-40 minutes, so it's not. I mean, some of the NICE guidelines are very complex, hundreds of pages. But this is a short, compact, great document. I mean, Mary Ann Lumsden, who's the lead, did a great job. And I would struggle to find anybody who's treating women in their day-to-day job who can't find 40 minutes to read it. It can contribute to part of their annual appraisal, so they can put down that they've reviewed the guideline, maybe precede it. So there is there's another benefit to looking at it. I have to say I don't agree with the view that you got from NICE.
Right.
And it's perhaps not quite as black and white as patients may believe. But the bottom line is, whether you're a GP or a gynaecologist, if you are treating menopausal women, and that's, so I'm talking about people who are actively seeing menopausal women, so obviously that's not all GPs and all gynecologists. But if you are treating somebody who falls into that category, then in my view, and I would strongly argue this in any legal case, you have a statutory and professional requirement to be up to date with current practice.
Right.
Now, that wouldn't necessarily say you need to know the NICE guidelines inside out, but within the current practice umbrella, you need to know the key factors. You need to understand body identicals, bioidenticals. Let's not get into that argument.
That's a whole other blog.
Absolutely. But you need to be up to speed on, for example, the thrombosis data that's come out, the great cardiovascular data that John Stevenson produced this week on the BMS mission statement. You have to be making that part of your portfolio. And I honestly don't see how you can practice good quality medicine, good quality HRT without that information. I think it's essential, and you can see it in the doctors who are practicing currently and offering women good treatment. They're generally fully up to speed with what's going on. They know about the developments, the research, and the trend towards modern HRT. It's not a big task, it's and if GPs can keep up to date with the diabetic guidelines, hypertension and so on, I don't see why menopause should be any different.
Particularly bearing in mind that
half the population. Absolutely.
Absolutely.
And within a practice, if you've got 10 GPs, they're not all going to be seeing menopausal women. That's not what NICE is recommending. What NICE is recommending, and what I would recommend, is within a practice you have perhaps a handful, 2 or 3 GPs who have their own interest. They want to treat menopausal women. Therefore, if you're interested in the subject, of course you want to read the NICE guidelines. Why would you not? So
absolutely.
That's the way it should be done.
Now, something that often comes up, and I think as sort of members of the public we don't necessarily understand, is the term duty of care. So a doctor's duty of care. Could you, I know it's probably a huge subject, but could you briefly, for a patient, outline what duty of care means?
Well, duty of care is the, if you like, the legal description for the relationship between a doctor and a patient, and it is any doctor, and in fact is any midwife or nurse, any healthcare practitioner. So the duty of care is that specialist has to provide the patient the level of care to the best of their ability, and that should follow current guidelines as far as possible.
So that's an interesting point, isn't it? That it should follow current guidelines.
So you could have, I mean, let's be sexist here, you could have an old codger or an old lady who's at the end of her, maybe coming up to retirement. They may have huge experience behind them. But if they are practicing with a body of knowledge that's 10 years out of date or 20 years out of date, which sadly happens, they cannot be offering a patient a good standard of care, and some of that care could be deemed to be negligent. Over my career, there has been a huge shift between not what you learn. You don't base your care on what you learned at medical school or what you learned as a junior doctor, and that's enshrined in the annual appraisal. You have continual professional development, or CPD, which isn't just for doctors, it happens across all professions.
I was going to say, it would be very much like if you worked in law.
Of course.
You couldn't work on...
You know, if there's a high court judgment and there's case law, you need to know it. And I don't think doctors should be any different. It may mean that you do have to devote more time to looking at the guidelines and reading articles and actually putting them into practice. But it's not just about your skills as a doctor, it's about having that up-to-date knowledge. And sadly, the way medicine is moving, you could be the best doctor in the world, the kindest, have the best interpersonal skills, but if you're not offering your patients what the guidelines say and what's deemed to be reasonable on the basis of scientific evidence, you are opening yourself to complaints, litigation, and obviously you're not offering your patients the best quality care.
So one of the questions that comes up all the time, so we're a group now of just under 7,000 women.
Wow.
So one of the questions that comes up all the time is, if I have independently researched HRT and what's out there, can I be refused it because of a lack of up-to-date knowledge from the GP that I'm seeing?
Well, there's two answers to that. The correct answer is, in an ideal world, if the GP is behaving in a reasonable manner, the short answer to that is no. Sadly, in reality, the answer is yes, but it shouldn't happen. I mean, what should happen in a situation like that is the GP should have a discussion with the patient, obviously look at the data she's brought, the evidence, and assuming she's being reasonable and it's from a good website, or it's from NICE or Menopause Matters or Health and Her, one of the many websites, all robust data, and she has a reasonable indication, either symptoms or family history or osteoporosis prevention, then I genuinely find it difficult to understand why that request could be denied. That's a reasonable request on reasonable grounds, and if it's backed up by current evidence that is soundly based and it's not mad internet quacky stuff, which is obviously not what we're talking about, then the answer is no. If that doctor either doesn't have the background knowledge or the confidence or the competence to prescribe, then the only reasonable step they can take is to refer the patient to one of his colleagues at the surgery or a local surgery, because there are GP experts that cover different, sometimes there's a hub and spoke arrangement, or failing that, it would be the local NHS menopause clinic, which can be accessed through the BMS website.
So that's all great advice. However, what happens if they're simply told, no, you can't have that, you can have tablets, and that's all we're prepared to offer? Then what, as a patient, what can the patient then do? So
if the patient has the knowledge, which hopefully the GP would have, that we now know beyond any doubt that transdermals carry no risk, not even a reduced, but no risk of thrombosis or hypertension, two of the biggest problems in that GP see in their practice, and if they show that evidence to the doctor, or show the data from NICE, and the GP still refuses, then in my view, categorically, that is negligent practice.
Okay.
Now, clearly, the patient isn't going to want to get in a standoff, accusing the doctor of being negligent.
No.
So what the patient then, I would recommend, I would ask the GP why. There's a clear blue line now between oral preps, transdermals, no doubt. I would ask the GP to substantiate their view, and it's not on cost grounds, because we know that the cost is not an issue. Yeah. Medications are very similar. Yes, absolutely. And if there's not a reasonable discussion, the patient then asks, okay, is there a specialist in the practice, somebody who has a better knowledge? I would like to see them. If not, then I'd like to go to one of the local menopause clinics.
Right.
And that, as with any specialty within medicine, if the GP, if I see somebody, for example, who needs colposcopy or who has a bladder problem, I can obviously give general advice, but it would not be appropriate for me to treat somebody like that. I would go to a colleague who has the requisite subspecialty training, and in return they would be sending me menopause patients. That's the way medicine works. Nobody can be a specialist in every field. I can't, GPs can't, but you have a duty, an absolute duty, to refer to a colleague who has either reasonable knowledge, better knowledge, or is particularly skilled in that area.
Okay, I'm going to take this one step further, just because we've had a situation come up today where somebody has been through that process. They've said they would like X, they've been told no, you can have this. They've said, well, in which case could you refer me to a menopause clinic? And they've been told this practice never refers to a menopause clinic. We do this in-house. Right. Is there then, is it then about speaking to the practice manager?
That's a shocking situation, and I've seen many difficult problems, and you can't countenance that. Doctors are not kings, they're not autocrats. They are there to assist the patient to the best of their ability. And if that ability means, sorry, I can't help you, I don't have the knowledge base, but I'm going to refer you to X, that's what they should do. It's completely untenable in 2019 that any GP practice says, no, we don't refer. That has no place. Even prior to the NICE guidance, I don't think it had a place, but certainly after, it doesn't. So that GP has to refer. The patient's in a very difficult position.
Exactly.
But it has to start. This is a situation where you're now escalating, and I think this is beyond a friendly discussion. She needs to put her concerns in writing, politely but firmly. That would go to the practice manager, and there will be a lead GP. And I'm afraid the CCG has to be copied in. The relevant person, if they don't know who to write to, because CCGs are often huge entities, I would write to the chair. All of that information is available on the internet. You're effectively flagging this up as a formal complaint in a positive and supportive way. And hopefully either somebody at the practice would finally come to the senses, or the CCG will step in. That is just untenable. You would no more get a GP saying, well, you're diabetic. Well, we do everything in-house. You're not going to see a diabetic specialist. It's ridiculous.
Exactly. I think the difficulty is, and you will know this, having seen an awful lot of menopausal women in your life, some of those women can be in a fairly fragile emotional state.
So they don't want to start getting into very confrontational.
But when it comes to a case like this, there really doesn't seem to be an alternative than to escalate.
And the good thing is that there's one, obviously it's very confrontational sitting across the table from your GP, but if you go home, calm down, write the letter, and then they could get their partner or a friend, supportive friend, to help them, to help them write the letter. It takes the heat out of the situation, and they can reference a letter. I'm all for, here's the NICE guidance, here's the, the internet tag, here's the tag, within the BMS website, there are leaflets that you can download that show categorically the differential risk between oral and transdermal. You can put all of that in the letter, so it's beyond any kind of dispute.
Yeah.
You know, what happens after that is very difficult, but I think it's very sad when the relationship ends up at that stage.
Yeah.
And it's actually quite frightening. I mean, as a specialist, I think, what is the mentality of a GP surgery who would be sitting there saying to their patients, we will not refer you? I think that's frightening on a professional level, and it's very concerning. It's certainly discriminatory, and I hate to say it, but it's steering into misogynistic territory, because it's women, it's all women who are going to be affected by that. So, you know, very, very difficult area, but got to be met head on. Yeah,
absolutely. I think your answer is probably going to be quite similar here in what you've said, but we've also had several cases of women who have been just told, we don't prescribe HRT. As in, we don't agree with it, we don't prescribe it. I'm guessing it's a similar thing. It's back to...
I mean, the trouble is, it's so far from my... It's almost like saying, you know, the moon is made of cheese.
It's like the Dark Ages.
But it's shocking. I mean, it's shocking and awful. You know, it's just ridiculous. I mean, again, it's the similar story. You've got to say, but why? You know, try and, you know, perhaps try and keep it a friendly or supportive discussion before you meet it. You know, get to loggerheads. In my experience, I usually find when I lecture, if I get that sort of response from GPs, it's usually because they're frightened themselves, they're coming from a point of lack of knowledge. So they're anxious about prescribing and being found out. Oh, if I do this wrong, what will happen? It's very rarely that they don't want to prescribe, it's just they don't have the skills, you know. And of course, what you do is you refer to a colleague, and if the practice, you know, if you've got a large practice, nobody there is skilled enough, you have to refer to back into the, you know, the hospital setting and to the local menopause clinic. You know, but I think usually if the patients understand that the GP's possibly ill at ease, poorly educated, and that's what's at the back of it rather than anything else, then that might help them understand why.
Absolutely. I mean, and sometimes when you're feeling very emotional and very desperate, that can be quite a difficult thing to do, can't it?
Especially when there's so much positivity around now, and they read on, you know, Twitter, social media, on the internet, the BBC Breakfast series last week. It's overwhelmingly positive. So I can only imagine that to go along absolutely distraught, and at the end of your tether, you go to your GP and you're shown the door. It must be devastating, you know, and
I think particularly, you know, when you see that other people are benefiting so much, and maybe it's been a bit of a light bulb moment for you, it can be very difficult.
But I think they've just got to plough on and, you know, put it in writing if it starts to get out of hand, so you don't end up in a meltdown, and reference what you write and say, please answer this within 14 days,
X amount of time.
Absolutely. And nobody can disrespect or disregard a request like that.
Okay, so this is sort of something that's currently going on and has come up over about the last week, so it's perfect timing to be sitting down with you. We currently have a handful of ladies on the group who actually, despite the fact that they still have their womb, so need progesterone, have been prescribed estrogen only, and not for a few weeks, for several months, some of them. Now, what happened was somebody posted and said, I've been reading something and I'm not sure that I'm correctly prescribed. We then discussed that. Several other people saw that and said, oh, hang on a minute, that's me too. Now, those women are now wanting to go back to see their GPs and to say, we don't think that we've been prescribed correctly, but they want to do it in a very proactive and productive way. They don't want to go back and sort of have a row. They want to go back. So what would your advice be to those women?
So actually not too dissimilar to the other two pieces of advice. So
approach the GP that prescribed first.
Right. Otherwise, if you go to a colleague, you're effectively complaining about them behind their back, and you're already adding a different element to the discussion. So I would go back to the GP, armed with a NICE guidance, clear as the light of day, and they could say, probably best not to say it came across on social media, because that doctors
that never goes down well.
NICE guidance, I was recommended to read this by a friend, or I read it online, and I don't think I'm on the right preparation. So any sensible and competent GP will probably realise immediately that there's been a slip up, apologise and correct it. The reality is that if it's just been a few months, the risk to the woman is minimal. I wouldn't want to say negligible, but it's minimal. And the risk of hyperplasia or any abnormality is slim. If it's a few years, slightly different kettle of fish. The GP may wish to get a scan done, or perhaps refer the patient to a gynaecologist for a checkup to reassure her, particularly if she's had bleeding or anything untoward. That's the way it should be dealt with in an ideal way. And the good thing is that hopefully that would be a learning experience for the GP. Hopefully it would just be a one-off, but if the GP then realises that there's been perhaps a catalogue of errors, they would take
hopefully
that on board.
Would flag that up.
Yes. If it's a more serious situation where the GP isn't open to discussion, then we're clearly getting into different territory, because as you know, and as I know, and as we discuss all the time, you need combined HRT if you haven't had a hysterectomy. That is black and white. It's not open to debate. Obviously there are different types of combined HRT, but you need progesterone. And I would be very worried about a GP who's prescribing HRT who's not aware of that key guideline. I see it all the time, sadly. I will see a handful of women like that every month, and the GPs are usually mortified, and some of them, they don't even speak to the patient, they just say, right, go and see somebody to sort this out. And obviously I just say, look, it can happen, busy GPs, writing prescriptions in a hurry. So I think it will always be a potential risk, but the point is, once it's picked up, it's addressed robustly, and the GP acknowledges that they've got a learning issue.
Okay. The T word, testosterone. So can you tell everybody what it is that NICE guideline says? And then, so what we generally have is, it's generally women who have had both womb and ovaries removed. They've had several months on their estrogen. They are still struggling with libido, with self-confidence, with mental
energy,
clarity, and exactly. They then go back because we talk about the guidelines, etc., and they say to their GP, I've been reading about this, could I have this? And very often they'll say no, because it's off license, you can't have it. And then what does the woman do, essentially? So can you talk about what the NICE guidelines say and how that should be interpreted?
Right, testosterone, I think of all the things we're discussing today, and a lot of it's controversial, I think testosterone, I would be the first to say, it's probably the most controversial of everything. And it's a nightmare, and I'll be the first to admit that. The key problem is it's off license. And it's off license across the board. People then argue, but Progestane's off license, and yet we're using that for endometrial protection. But that's different, because progestogens as a category are not off license. It's just that one particular product. The point about testosterone in the UK, all of it is off license. It's a really thorny issue. Now NICE actually gets by because it doesn't come off the fence. That's what NICE does. If they don't want to offend this camp or that camp, they sit on the fence. But the reality is, it is essential, or certainly very helpful to certain women, including the group that you've mentioned. And I think the bottom line is, we need to sort this issue out of licensing. And I don't blame NICE for that. I'm certainly not blaming GPs. If they can't get to grips with the basics, testosterone is just it's just the final straw. And even specialists like myself have to dip our toe carefully with testosterone, because if you don't get it right, it can be really problematic. So I think the key thing is the BMS and the colleges, particularly my college, need to get together with the licensing agencies and sort out where we're going. There needs to be much more robust guidelines, because it's out there, it's in the public domain, it is available privately, and some GPs are prescribing it on the NHS, so the whole thing's a mess. There is not a standard nationwide policy that everybody's following.
And I think that's the difficulty. And some say they've got it, others say absolutely not. It's very confusing.
And NICE, did the best. It wasn't licensed in 2015. 4 years later, it still isn't. And sadly, I would say that's the one area of HRT we haven't really made progress in. I know the BMS are doing their best. Nick Panny has done a huge amount to publicise it. He's very pro. He has. But one person can't do everything. So I think there needs to be a concerted effort for menopause specialists to say that's the next thing on our agenda. The problem, once you've agreed that, is actually getting a safe protocol. The trouble is, within testosterones, they're all slightly different formulations, they're different doses, so you can't replicate
products are different strengths, aren't they?
And then, of course, we've got the new kid on the block. We've got Androfem, which is coming over from Australia, which I'm now prescribing. But part of me feels very uncomfortable about that, because although it's the only testosterone that's available that's formulated for women, it's private and it's expensive. And although
it's
the
over
data
£100,
said it's £120 for a tube, so it's something like $120 a day, which, as the patient said, well, that's half a cappuccino, so if you balance it, but I'm the first to admit that everyone can't afford it, and there is, as far as I'm aware, there's no prospect of that being available through the NHS ever, and certainly not at the current time. So even if you want to offer it, you then feel compelled to give patients the gold standard, which I believe is Androfem. It's the only one I would recommend 7 days a week, and it comes, with a metered syringe. It's a mess.
So for those who've rectomised women, so the women who've had their ovaries removed, for those women, would you suggest for those women that they really do push quite firmly for a referral to a menopause specialist?
So, the surgical menopause, as we know, is significantly different to a natural menopause. It's usually very abrupt, particularly if the woman is in her 30s and 40s. And because of the loss of the ovaries, there's not just a precipitous drop in estrogen, but testosterone diminishes as well. And of course, in a natural menopause, there's still a reasonable amount of background testosterone, which is probably one of the reasons many women can get by. And actually, we all know menopausal women who don't have an issue with libido and so on. So I don't think it's for everyone, but those who need it, and the oophorectomized group need it for a very clear anatomical reason, because their testosterone levels will be extremely low, sometimes outside the normal range. And they do suffer, not immediately, but if you meet somebody who's lost her ovaries, who's not on testosterone, 4 or 5 months down the road, even if she's on good quality estrogen, she will probably be, her libido may suffer, energy levels. If she exercises, her endurance will be affected. And many patients just say there's this sort of indefinable loss of joie de vivre, or a patient said to me the other week, I've just lost my mojo, and I can't, that's it. I'm not depressed, I'm not going mad, but I've just got this, everything's I've lost this appreciation of everything.
That's me, so that was my situation. And testosterone for me was the sort of the final part of the jigsaw when I felt much better, but it was kind of, sort of, where's my self-confidence gone? And it was getting testosterone, it was like, that totally makes sense.
And it's difficult to, it's much harder to explain than vasomotor symptoms or not sleeping at night or having a weak bladder.
It's less defined, isn't it?
But when I'm seeing, when I'm talking to a patient and their estrogen levels are great and they're otherwise fine and their bones are good, and they have this remaining disappointment. You know that that's what it is.
Yeah.
Now, my view is that at the moment, I don't really think that GPs. I think this is one area of menopause practice that I think it is beyond most GPs.
Yeah.
I think if somebody has had specialist training or has their BMS ticket, of course they know what they're talking about. But your average GP, this is almost a step too far.
Yeah.
And the worry is they might get it wrong. They might overprescribe or underprescribe, and that will be ineffective.
Yeah.
I think levels do need to be monitored, and you need to know how to interpret those levels, and you need to be doing that every day, not once in a blue moon.
Yeah.
So I think it's the one area where the local specialist can really come into their own, either in a clinic or by email support or whatever.
Yeah.
And this is the one area where I think GPs need to collaborate with the specialist.
Okay.
Then once the patient's on the right track, they can go back to the GP, and the GP says, this is what I've got to prescribe, or if it's androfem, then it may have to be a private script. Okay. But I would feel uncomfortable with GPs taking that responsibility on themselves.
Okay.
Yeah.
So this is a GP question.
Yeah.
So the GP has asked, can a CCG, so that's a clinical commissioning group, can a CCG tell a GP not to prescribe something if it's on the drug tariff and the doctor feels that it's in the patient's best interest?
The answer to that is no. Because GPs, as are all doctors, they're independent practitioners in our own rights.
Okay.
We have, as laid down in the Hippocratic Oath and the requirements from the GMC, our duty is not to the CCG. And if I was employed by a trust, it wouldn't be to the trust, it's to the patient sitting in front of you.
Oh, that's interesting.
That is the relationship legally.
Okay.
So, when doctors are sued, it's because that relationship is broken down,
right,
and that is not being carried out to the best of the doctor's ability. So the simple answer to that is, as long as the drug is recognised and registered, it's in the British National Formulary. If it's not on the local CCG formulary, but it is still in use, in general use in the country, whether it's off licence or not, then that doctor has a duty of care to prescribe it. If that's in the patient's best interest.
Okay, interesting. Yes. So this is probably my last question, and then I want to ask your view on something. But so a few months ago, I flew up to Glasgow and I gave a menopause presentation to an organisation. And at the end of the presentation, a young lady, only in her 20s, came up to talk to me, and she was clearly very emotional. She was a woman who has a grandmother, a mother, and 4 aunts who all went through menopause at the time when basically HRT was flushed down the loo.
And you got on with it.
Yes, due to the WHI. All 6 of those women have osteoporosis. So she knows that it's likely that unless she... And they're all... Sorry, the thing I didn't say was they're all early menopause.
Right, so she's got a double whammy there.
Yes, so all women in early menopause. And she was clearly very angry about that on their behalf. And this sort of this lack of factual evidence-based information and this piece of research which really muddied the waters.
Yes.
So we had a conversation around it, and more recently somebody in the group has said that actually they were not offered HRT as a POI woman.
Yes.
She now has osteoporosis. She's very angry about that, understandably. Yes. And she has asked if she has any recourse. Now, that, for me, I would hope that was never going to be an issue. That's not something that I would want people to have to get into. Yes. But she's now asking, is there a recourse?
The short answer is very, very likely yes.
Right.
And this even predates the NICE guidance, but of course it's become much more clear cut since NICE guidance came out, and I presume Some of those cases would have been before that, but probably the more recent cases are after that. So we have known for years. When I did my research in the 90s, we knew there was cast iron, grade A standard, evidence that estrogen protects against osteoporosis, and in some cases actually builds bone density back up, so it can start to reverse the change. The only other group of drugs which can do that, as you probably know, is bisphosphonates. The difference being that bisphosphonates have a short-term license, you cannot use them long-term, and the minute a patient stops bisphosphonates, the bone density drops off the edge of a cliff. Whereas the beauty of estrogen is you get a 10-20 year lag where bones will be stronger. So there are differences between the categories. Similarly, doctors have known for decades that the main risk from POI, apart from the cardiovascular risk, is osteopenia and osteoporosis. It's an entirely preventable disease. It can be life-threatening, life-ending. It's a serious condition.
Can I just say, POI, premature ovarian insufficiency. So that's women under the age of 40, sometimes under 30, sometimes under 20.
Yes. So that group of women, again, are, I hesitate to say they're high risk or unusual, but I don't believe they're the category who should be managed by GPs. I think there's too much to deal with. You're not dealing with just the immediate menopausal symptoms which you get in the 50-year-old category. This is actually a life-changing event, and if you don't get it right, it could be a life-shortening event. And instead of living into her 80s, this group of women may, suffer problems 50s, 60s and beyond. I think this group of women should be seen in a specialist clinic, if at all possible, and in that setting, everything will flow. There will be the appropriate discussion about the long-term cardiovascular and bone density risks, access to DEXA imaging, which is mandatory. Even if you're on HRT, you need to have your bone monitoring every 3 to 4 years, or however often it's recommended, and the full range of backup will be available there. I would say categorically now that anybody going through POI, premature ovarian insufficiency, even if they don't have that family history that that poor girl had, I say HRT is mandatory until the average menopausal age, which is 52. So you tack on, if you're 37, you're going to take it for 15 years, and it shouldn't be open to question. And if somebody objects to that, I would be arguing, what about your long-term health beyond 52?
Absolutely.
This is not short-termism. This is what's going to happen when you're in your 50s and 60s. Bones, cardiovascular, and you have to be able to have that detailed discussion, which I don't think should be the role of most GPs.
Okay, that's really helpful.
Litigation. As I said to you earlier off camera, I've got several menopause cases on the go, one of which is very similar to this, the poor lady that you mentioned, family history of osteoporosis. She herself had an early menopause and had a discussion, was put off HRT by her GP, and she's only in her mid-50s, and she has the bones of a 70-year-old. She's got established osteoporosis at hip and spine. She's already got a dowager's hump. She's on bisphosphonates. But it was all preventable, and her life is it's been catastrophic. And she had the dialogue, and the GP categorically stated that there was no need for HRT and she'd be fine.
That's so sad, isn't it? So sad, and so it just didn't have to be.
No. And those cases are major. These are not, if somebody has lost their income, they can't work, they are in chronic pain, they need hip replacements, fracture repairs. This is, meaty medical legal stuff. The lawyers' eyes light up when they see this, because they see it's not a trivial issue. And I, when I present, I say, listen, the one thing doctors don't want to do, they hate being sued, and they do not want to be told what to do by lawyers. Doctors hate that, and I'm the same. So I would encourage people, do it spontaneously, get up to speed, and don't make the lawyers force you to do it, because that's the last thing we all want.
Yeah, absolutely. Thank you so much. It's been so helpful. You have been very supportive of the aims of the Menopause Meta campaign, and I thank you for that. As you know, the campaign is calling for mandatory GP education in menopause. It's calling for awareness and guidance in every workplace, and it's calling for inclusion in the PSHE curriculum. I know that you support that, but from a professional point of view, what would you like to see?
I mean, anything, at the risk of being tried, anything other than the current situation would be an improvement. And I'm joining you. You know, from my social media, it drives me mad. There is no mandatory training for any doctor, and the vast majority of doctors, whether they're GPs or orthopaedic surgeons, will go through 6 years of undergraduate training, God knows how many years of postgraduate training, and they may never sit in a menopause clinic, never see a menopause patient.
And we have the same situation with gynaecologists, am I right? That not all gynaecologists
they go through the same basic training, and if they happen to do their postgrad training in a hospital where there isn't a menopause clinic, as is the case in most hospitals, and they don't then do a sabbatical where they can attend a clinic, they will not get any menopause training. And so it's a complete misapprehension that if you go to see a gynaecologist at a local hospital, you're going to get any better advice than you would from your GP. The chances are you may not. So this is not an issue about GP education, it's an issue about education of all doctors, and then perhaps more specialist menopause education for those who are going to treat women, such as myself, gynaecologists and some GPs. Even orthopaedic surgeons and cardiologists need to know. The cardiologists need to know about the huge benefits in health prevention. I still get cardiologists saying to women, oh, you can't have that, it'll give you high blood pressure, and you've got stents, and you've had this, and you've got a heart murmur. It's the very thing you should be having. So I think it should be mandatory for all undergraduates, just to give them a flavour of the current state of play. And then those of us who go on to do it in a more specialised way, obviously they're going to be keen to get additional knowledge. And how we introduce that, I don't know, because to educate the thousands of medical students, you have to have the experts educating them. But we've got to get off the starting block and at least agree that that's what we should be aiming for. I mean, it may take us 5 years to get there, maybe longer. But at the moment, the two colleges, my college, the Obs and Gynae College, and the GP College, haven't even agreed that. And I think there is this unfortunate misunderstanding and misapprehension that there is adequate education out there, which I know there isn't, and you know there isn't, and my patients tell me there isn't, and GPs tell me there isn't. So there's this miscommunication.
And that's really interesting what you just said, because I think that's really sad. In the fact that so earlier this week I was up at Louise Newson's with 39 GPs on an education day. And they were so keen to have the knowledge. Now, I'm not saying everybody would be, but they were so keen to have the knowledge. I know that, colleagues of yours have, I know that you do training. And when I then speak to those GPs, they're like, oh, this is great. I did my training with practice nurses and breast cancer nurses and gynae nurses. They want to know, and I think that's the sadness, is that these people want to have this information. The fact is that the training simply isn't there. So the people that are in charge of that really need to get on with it and do something about it.
I couldn't agree more, and I know Louise herself has spoken to the chair of the RCGP, and there is activity going on in my college. Maybe I appreciate that there's so many agendas the colleges have. That they're juggling everything, and my college is juggling obstetrics and stillbirth rates and maternal mortality and cancer. But I think there needs to be a concerted effort to get menopause up the agenda, because, as we keep saying, it's the one thing that affects every woman who gets to 50 will go through the menopause, and it's 51% of the population. It's millions of women. Much as I support advances in obstetrics, every woman is not going to be pregnant, nor does every woman want to have a baby. So we're focusing on something that's affecting a much smaller percentage of the female population. I hope that perhaps with the changeover in personnel at the colleges, change will come. And I think, you know, as the saying goes, you chip away. You know, you've got the...
we keep going.
Absolutely. You know, it's the publicity with Rachel Redditch and so on. You know, there's Rachel McLean rather.
Yeah.
You know, there's a lot going on, and I think if there isn't a blue sky moment, I think the constant chip that everybody does will eventually pay dividends.
And I think the thing is now, because we have this collaboration of, you know, sort of doctors, clinicians, patients, etc., patient experts, we're now in a position where actually this isn't going away.
Yes, no, I agree. And I think you've got to have, as you say, you've got to have a mix of everybody. If it was just non-medics or just patients or just patient support groups, it's difficult. But when you've got, I mean, I know Louise is very supportive. There's myself, you know, there are numerous other medics you've got to, absolutely. You know, I think when you've got people who are, this is my day job. You know, so I don't do this as a hobby. This is my day job, and I've got decades of experience, research, clinical. You know, I'm speaking from a wealth of knowledge. And you know, there's no benefit to me to spout off if what I'm saying isn't true. But I see it day. I see it when I lecture to GPs and practice nurses. I see it when I see patients, when I speak to people like you. And you think if something is there in front of you, it's there all the time. There has to be, you know, a truth to it.
We can't just keep doing it like we've done it before.
The definition of madness is doing the same thing again and again. Was that Einstein? Hoping for a different outcome.
Absolutely.
Yes. So there you go. That's it.
Thank you so much. It's been fantastic.
Very enjoyable.
I've kept her for at least 10 minutes over what I should have done.
My section going,
so I hope you found it really useful. If people want to contact you, could you just tell them how they can do that, where you practice,
can get me on Twitter. I'm always very vocal. Always getting my knuckles wrapped. When somebody says I've seen something on Twitter, I think, shit, what did I do? What did I say last night? You know.
Was it me?
So, no, I know. But failing that, you can get me on Twitter. Failing that, I will give you my secretary's email address. She's going to kill me for this.
Okay.
It's Judith, Judith, at gynae, gynae expert.co.uk. So that's Judith at gynae-expert.co.uk. If you want to email her, she's going to kill me now. Because she gets about 500 emails a week already. So, but she will answer. I can't promise that she'll answer, you know, within 48 hours, but she's very good. She'll have a folder with
fantastic.
responses.
And if people have seen this and they think, do you know what, I'd really like to go and see that woman, email
Judith.
Okay.
I'm in London.
Is it Maidstone in Kent?
Maidstone and Sevenoaks, and I'm here in London, which, you know, is pretty central. We're in central London. So I'm very happy to see people. And women can self-refer. You know, if you want to come with a GP letter, that's great. But if not, come armed with your medical history, and very happy to see self-referrals. In fact, as you know, it's an increasing, you know, women just give up, get desperate, and they just pick up the phone and make an appointment.
Fantastic. Thank you so much. It's been super.
Good.
So I hope you've enjoyed it. I hope you get something out of it. If you watch the video, do drop us a message afterwards. And as you know, if you want to contact me, menopausesupport.co.uk or the Menopause Support Network on Facebook. And as ever, if you haven't yet had a look at the campaign, please do and consider signing the hashtag Make Menopause Matter campaign, which you can also find on Menopause Support. So I hope it's been useful for you, and we'll see you again next time for another one of these somewhere else in the country. Thank you.
Bye-bye.